When Trust Turns Deadly, a medical crime documentary narrative by Dr. Emily Carter. Opening, the unsettling question. What is more disturbing? A healthcare worker secretly harming patients, or the system meant to protect lives quietly failing to stop it? Most people walk into hospitals believing they are entering one of the safest places in society. Medicine is built on trust. Patients surrender control, often in vulnerable moments, expecting care, skill, and compassion. But history has shown that trust, when combined with institutional blind spots, can sometimes create a dangerous environment. Today, we are exploring one of the most chilling examples of that reality, the story of Charles Cullen and the systemic failures that allowed harm to continue for years. Hello, my name is Dr. Emily Carter. This is not a sensational horror story. It is a sober examination of psychology, healthcare responsibility, and the consequences of ignored warning signs. Let's begin. Early life, seeds of instability. Charles Cullen's early years were marked by repeated loss and emotional hardship. Losing both parents before adulthood is a traumatic experience capable of shaping a person's psychological foundation. Childhood grief, when unsupported, can evolve into chronic isolation, depression, and identity disruption. Accounts from those familiar with his youth describe a quiet, withdrawn individual struggling to connect socially. Bullying and alienation reportedly deepened his sense of detachment. Psychologically, early trauma does not automatically lead to violence, but it can create vulnerabilities, particularly when emotional regulation, belonging, and self-worth are never fully developed. Searching for structure, Cullen enlisted in the Navy. Military life, pressure without relief. Serving aboard submarines is psychologically demanding. The environment is confined, high stress, and socially intense. For someone already struggling with social integration, this setting can magnify emotional strain. Reports suggest Cullen continued to face interpersonal conflict and ridicule. Alcohol use, impulsive behavior, and emotional instability followed him through this period. The military experience did not stabilize him. It layered additional stress onto an already fragile psychological profile. Eventually, he left service and turned toward healthcare, a profession rooted in responsibility, routine, and human care. On the surface, this appeared to be a constructive new direction. Entering healthcare, a mask of normalcy. Cullen trained as a nurse and entered hospital work, a field that demands precision, compassion, and trust. By outward appearances, his life reflected stability. He maintained employment, built a family, and functioned professionally. Co-workers often described him as quiet, reserved, and unremarkable, someone who blended into the background. Yet hospitals are complex ecosystems. Critically ill patients, rapid decision-making, and unpredictable outcomes can create environments where anomalies are difficult to detect. And within that complexity, patterns began to form. The invisible pattern: explained patient deaths. Over time, unusual medical events appeared in facilities where Cullen worked. Patients suffered sudden declines, inconsistent with their expected clinical course. Medication irregularities surfaced, yet each individual incident could be explained away, at least initially. Healthcare is not a controlled laboratory. People die in hospitals. Complications occur. Medication errors happen. This inherent unpredictability can unintentionally conceal deliberate harm. Investigators later determined that Cullen had access to drugs capable of inducing fatal physiological reactions when administered improperly. What made the situation especially alarming was not only the acts themselves, but the institutional response. Concerns were raised, questions surfaced, but instead of immediate, aggressive intervention, issues were handled quietly. Transfers occurred, employment continued, documentation remained incomplete. The pattern remained fragmented across institutions, and the harm continued. Institutional blind spots: how systems fail. Hospitals operate under immense pressure: legal liability concerns, staffing shortages, reputational risk, bureaucratic complexity. When suspicious behavior emerges, organizations may hesitate. Internal investigations can be slow. Fear of public exposure or litigation can influence decision-making. This hesitation can unintentionally prioritize institutional protection over patient safety. The Cullen case revealed a troubling vulnerability. When communication breaks down between institutions, dangerous individuals may slip through the cracks. This was not simply the failure of one person, it was a systems failure, where incomplete reporting, fragmented oversight, and risk avoidance allowed preventable harm to persist. Psychological dimension: the hidden crisis. Understanding this case also requires acknowledging the psychological dimension. Healthcare environments are emotionally intense. Professionals witness suffering, death, and human vulnerability daily. Most adapt through training, peer support, and resilience, but individuals with unresolved psychological distress may respond differently. Isolation, depression, emotional detachment, and maladaptive coping mechanisms can distort perception and behavior. While mental illness does not equate to violence, unaddressed psychological instability combined with access to vulnerable populations can create serious risk. The lesson is not suspicion, it is proactive support, screening, and oversight. Exposure: when patterns finally connect. Eventually, cross-institutional awareness began to piece together the anomalies. Medication tracking, investigative persistence, and whistleblower courage exposed a consistent pattern. Authorities intervened. The case triggered widespread shock, not only because of the harm inflicted, but because warning signs had appeared repeatedly across multiple workplaces. Healthcare institutions were forced to confront uncomfortable truths about reporting failures and communication gaps. Reform and aftermath: learning from tragedy. In the wake of this case, healthcare systems re-examined critical safeguards: tighter medication control protocols, improved inter-hospital communication, stronger reporting standards, whistleblower protections, background monitoring. These reforms aim to reduce the chance of similar failures. No system is perfect, but systemic learning is essential to rebuilding trust. The larger lesson: trust must be protected. Medicine depends on trust, but trust must be supported by structure, transparency, and accountability. Healthcare safety is not guaranteed by goodwill alone. It requires vigilance, ethical leadership, and systems capable of detecting rare but catastrophic risks. This case is unsettling precisely because it reminds us that even trusted environments require oversight, not out of fear, but responsibility. Closing reflection. Cases like this are rare, but their lessons are critical. They teach us that protecting patients demands strong systems, open reporting, psychological awareness, and institutional courage. Trust is one of medicine's greatest strengths, and safeguarding it is a shared responsibility. Thank you for listening. Take care of your body. It carries you through life. Subscribe for clear, practical health guidance.